ما لسه ما بدأتش. Good evening, everybody. Good morning, good afternoon, depending wherever is the world you are. It's my pleasure to be here with you today with the World Dental Association page, and it's really a great pleasure for me to make the lecture today with you. Our topic today will be a novel approach for optimizing aesthetic outcome. Actually, it's a new trend, or everyone now is talking about soft tissue management. Now, whatever you start, whatever you attend the lecture, it's about soft tissue management, and everyone is talking about connective tissue graft, taking connective tissue graft from the palate, from the tuberosity, putting it in aesthetic zone, and so on. But today, I'm going to introduce a novel approach, which is easy, because to collect the connective tissue graft from the hard palate or from the tuberosity and put it back in wherever the area is extremely difficult, and it needs an experienced clinician. But I'll explain to you an easy technique to manage the soft tissue management around the dental implant, so you can get a nice aesthetics and a nice emergence profile for your implant. First of all, allow me to introduce myself. My name is Ahmed Halim Ayub. I'm the president of the Egyptian Society of Oral Implantology. Also, I'm a visiting lecturer in Bari University in Spain, and I'm a board member of London Oral Restorative Academy. I'm graduated from Alexandria University in Egypt, and I finished my postgraduate studies from Seville University in Spain. This is a part of my teamwork, and actually they are helping me a lot, and I give them credit for everything I'm doing. They are helping me in all my surgeries. They are doing a lot of nice technique with me, and they are part of a big team, Egyptian Society of Oral Implantology team. In our society, we do a lot of continuing dental education courses in Egypt, in Middle East, wherever, everywhere in the world. We go in some Arabic countries, we go in Europe for continuing dental education. We do courses online, we do courses live, practical course, as you can see here, because patient or students come to our course and place implants inside patient mouths. We always like to do a good education, because when dental implants started, a lot of surgeons wanted to do it like a secret. They didn't want anyone to know how to place implants and the secret of dental implants. And actually, in the Egyptian Society of Oral Implantology, our mission is the simplicity. We are always looking to do everything in a simple way. How to place your implant in a simple way. This is our mission. How to do everything in a simple way. We always call our courses Art of Simplicity. And I always say, keep it simple and silly. You have to do everything in a simple way. So first of all, let me tell you about some introduction about my lecture today. Long time ago, I started to place implants from 1998, and at this time, our main concern was the osseointegration, because osseointegration was considered the only parameter to judge the implant success. And then later on, we started to talk about precise ceramic duplication. If you are making a good ceramic restoration, this will be nice. Okay, very good. But nowadays, the patient is asking for more. The patient is much more better educated. Patient is looking on YouTube, on Google. They know well about soft tissue. They know well about papilla. And the patient is asking you when he comes to place an implant in an aesthetic zone, doctor, are you going to regenerate my papilla or not? They know, they understand. So now the success is not only implant, osseointegrated implant. No. Now you need more. You need managing of your soft tissue. So when we talk about soft tissue management, we have to talk about something called emergence profile. What is the emergence profile? Sorry guys, there is a problem with the camera. Just a minute, I'll fix it. Okay, I hope it's working now. So let's go back to our lecture. And we will talk about emergence profile. What is emergence profile? Emergence profile is a contour of tooth or restoration while it emerges from the gingiva. This is what we can call emergence profile. So to get a good or to have a good emergence profile, you need two things. You need to reshape your soft tissue, and also you need a good lab to make a good restoration for you. So emergence profile, we are talking about soft tissue and restoration. Restoration is something related to your lab, but soft tissue is something that you can do. Usually we used to reshape our soft tissue using a healing abutment, and you have a lot of shapes of healing abutment. This is what everyone is using to reshape his emergence profile or reshape the soft tissue. This is what we can call a good emergence profile. You can see here we have a nice soft tissue, a thick keratinized band of mucosa around our future or around our restoration. This is what we can say it's a good emergence profile. We know that around the tooth we have something called biological wets. And also around the dental implant we have biological wets, or we can call it biological constant. Biological wets around the tooth, which is epithelial and connective tissue. But biological constant around your dental implant, it has to be about 3 millimeters of soft tissue. 3 millimeters of soft tissue, which is 2 millimeters of epithelium and 1 millimeter of connective tissue. So please remember, you need 3 millimeters of soft tissue around your dental implant. But Albert Einstein said something very important. If the fact don't fit the theory, change the fact. You can change everything. Anytime you can change any fact, anything to fit your work. Sometimes you face a problem with a patient with high aesthetic risk factor. For example, patient aesthetic expectation, high aesthetic expectation, high lip line, thin gingival bitype, which is really a big problem, and horizontal bone deficiency. Some patients represent horizontal bone deficiency. How can you manage this work, or how can you deal with this kind of patients, especially with thin gingival bitype? Because remember, I told you, you need about 3 millimeters of soft tissue around your dental implant. But thinning or destruction of biological constant thickness will lead to automatically peri-implant bone loss. If you place an implant with a soft tissue of about 1 millimeter, you will have about 2 more millimeter bone resorption to accommodate the biological constant around the dental implant. So you need a minimal thickness of mucosa, about 3 millimeter, for long-term stability of bone level. Of course, we don't want bone resorption around our dental implant. We want our dental implant with a good bone level. So if you have a thin gingival bite, you are really facing problem. And you have to know also, it's not only the soft tissue, you have to place your implant in the right three-dimensional position to simulate a natural appearance. Therefore, balance between anatomical and restorative consideration is really important to achieve optimum aesthetic outcome. When you have a case like this, you have a depression, you have a soft tissue depression, even if you have your implant placed in the right position, but the patient doesn't like the soft tissue depression, he's not happy with this. What can you do? Because you know that the soft tissue is creating the harmonious aesthetic frame around the restoration. Actually, the importance of soft tissue thickness around dental implant for maintenance of function and bone level has been widely reported in a lot of publications. The one I'm showing here sheds the light on the importance of peri-implant soft tissue thickness and the importance also of your right implant position, the placement of your implant in the right position on the longevity of implant. You see here in this publication, thin peri-implant tissues less than 2.5 millimeter will be associated with increased crestal bone loss. Oh my God. Another thing, increased incidence of marginal tissue recession 1.8 millimeter versus 0.6 millimeter with buccally angulated implant. So we all know that in upper anterior, you have to place your implant palatal as much as you can. 0.2 millimeter versus 1.17 millimeter of marginal tissue recession after 1 year of function for thin versus thick gingival bite type. You see in thin gingival bite type, what happens? 1.17 millimeter bone resorption and tissue recession, which means it's really important to increase the thickness of soft tissue or peri-implant soft tissue to prevent more bone resorption. To do this, I know you will tell me, yes, doctor, we can do this with a connective tissue graft. We can do this with free gingival graft. We can do it with rod flap, apical position flap, semilunar bevel incision. We can do it with a lot of ways. Periosteum releasing incisions, whatever. We can do it with a lot of ways. Yes, you are absolutely right. But, and according to the publications, everything I'm saying, you will find the reference down here. You will find in yellow or red the reference of everything I'm saying. So according to a lot of references, so using a connective tissue graft to increase the thickness of peri-implant tissues gives you a very good results and a better pink aesthetic score. Everyone is saying this, and it's totally right. But in some publications, they found that this technique sensitive. You see, it's technically sensitive procedure. Now I have 94 audience. I'm asking the 94 audience. All of you can get a connective tissue graft from the hard palate or from the tuberosity and put it in the static zone. All of you can do this in a predictable way? Of course, no. And let me ask you something else. If you are the patient and you came to my clinic and I'm telling you, look, doctor, look, my friend, I will take tissues from here to put it here. I will take bone from here to put it here. Oh my God, what doctor you are going to do for me? It's harmful for the patient. And it's really scary for the patient. And also, according to this publication, it didn't lead to less peri-implant bone loss. And sometimes necrosis happens to this connective tissue grafts. So it's not the magical way to solve the problem. Can we use, doctor, a cellular dermal matrix membrane? Because some people telling me, okay, we can use a cellular dermal matrix membrane. Yes, you can. But you know, it's very expensive and it's not that easy to do it. It requires a tricky manipulation. So how to do it with a different way? How to convince your patient without telling him, I'm going to take tissues from here, put it here? It's extremely a big problem for your patient. So someone called Tom Abbott, he said, it's not about being better. It's not about being better. You don't have to be the best dentist in India or in the world. It's about being different. It's about being different. You need to give people a reason to choose your business. You're not, I don't have to tell my patient I'm the best dentist in the world, I'm the best surgeon in the world. But I can tell my patient I can do it to you with a less traumatic procedure. This is more important for your patient than being number one in the world as a dentist. So how can we do it in a simpler way? How can you increase the soft tissue around the dental implant with a simpler way? The answer is fibrin. Fibrin is the answer. Fibrin is the present, and fibrin is the future. When I'm talking about fibrin, I'm talking about a lot of products. I'm talking about PRF. I'm talking, of course, you know about PRF, IPRF, APRF, whatever, blah, 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 PRF, CGF, PRGF, a lot of products, sticky bone, NPN. All of them, we can call it simply fibrin, or we can call it platelet concentrates. How can we use the fibrin to increase the soft tissue thickness around a dental implant? I'm using CGF. I used to use PRF a long time ago, but nowadays I'm using CGF. CGF is an abbreviation of concentrated growth factors. And CGF is one of the materials that can be used to achieve soft tissue augmentation and increase the thickness of soft tissue, especially in the aesthetic zone. How can we do it? Of course, we are talking about PRF, we are talking about CGF. The start was with PRF. We started with PRF. PRF was described by Dr. Joseph Chukron. It's a fibrin matrix enriched with cytokines circulating progenitor cells. Let me explain to you simply. PRF or CGF is simply a fibrin network, and you are getting it from the patient blood. I will explain to you now. But the fibrin network, and inside this fibrin network, what you have? You have white blood cells, you have platelets, and you have mesenchymal stem cells. Platelets and white blood cells secrete toxins or growth factors, not toxins, cytokines. Platelets and white blood cells secrete cytokines and growth factors. Growth factors it's a protein that induce the mesenchymal stem cells proliferation. It helps the mesenchymal stem cells to proliferate into osteoblasts, to proliferate into fibroblasts. So you have a concentration of mesenchymal stem cells and the growth factors in your hand when you are using PRF or you are using a CGF. How can we obtain a PRF or CGF? Simply, we collect blood from the patient, as you can see, then put it in specific, of course, in specific tube, and put it in a specific centrifuge. Here I'm using the Medifuge centrifuge from Silfrodent, Italy, to make the CGF. Then, after centrifugation, you get this final result. This is the PRF or CGF. There is no big difference. It's all commercial names. There is no big difference between CGF or PRF. It's almost all commercial names. And this is what I get. It has a lot of plasma inside. So first of all, I have to cut the red blood cells. Then I need to push it, to compress it, to get rid from the acellular plasma inside, and to make it like a membrane so I can use it later on. So I compress with the lid, I press on it and I compress. You see here, I'm compressing. And this is the final or our end product, which is the PRF or the CGF that you are going to use later on. You see now, if you go to, there is a website called ResearchGate, because I have a lot of researches on PRF, CGF, and sticky bone. Go on www.researchgate.net and look for any article you're searching for, it's for free, and you will find my articles. I have about 15,000 reads, and now it's more. It's reaching 17,000 and 46 citations, which is a good number. You will find a lot of my publications. I have about 24 publications. So you will find a lot of publications around PRF, around CGF, and so on. So now let me introduce to you how are you going to use PRF or manage in general your soft tissue in a nice way or an easy way. I published in 2016 an article in an English journal. It's called Vertical Mid-Crestal Incision Flap Design. Because, you know, if you'd like to make a papilla, if you place an implant in upper central and you'd like to create a papilla, you have to use a very difficult techniques like Palacci technique, like palatal sleeve flap, a very difficult technique. Okay, how can you do it in an easy way? Let me tell you. I called it reverse mid-crestal incision, and I will show you by video now. What you are doing is just, what you have to do is just a buccopalatal incision, one buccopalatal incision. Then take out your cover screw. You see, it's easy, it's not complicated. And put a narrow healing abutment here. Wait for 1 week and then take out the narrow healing abutment and put a wider healing abutment. What you are doing with the healing abutment, you are expanding your tissues, you are pushing your tissues mesiodistally. Why I'm using a narrow healing abutment than a wide healing abutment? If you are using a wide healing abutment, immediately you are going to press on your tissues and you may cause a necrosis. So you have to expand your tissues laterally, mesiodistally, using a narrow healing abutment than using a wide healing abutment. Okay, let me show you on clinical cases so you can understand the technique more and more. Here you have an implant placed in the right position and a thin gingival bitype. Then what we are doing, a buccopalatal incision. You see, just a buccopalatal incision, simple incision. I believe everyone can do this, a buccopalatal incision. It's nothing. Of course, it's much more easier than Palacci's and palatal sleeve flaps and a lot of other techniques. Then put your narrow healing abutment. What is happening now? The narrow healing abutment is pushing my tissues laterally, mesiodistally. Let me show you a very nice picture. Look at here, look at the soft tissues expanded mesially and distally, and also look at here. Now I'm expanding my soft tissues mesially and distally. Fantastic picture. Now what's next? Put a wider healing abutment. So you will get a better, you see here, you've got a better soft tissue. It's not totally a papilla, but it's a soft tissue just in the interproximal area. I will show you another case to explain more the technique. Buccopalatal incision, narrow healing abutment. You see the blanching. The blanching means you are pushing the tissues mesiodistally, and now I have to change with a wider healing abutment because this is not a good emergence profile. I need a wider healing abutment. So now, yes, now it's a wider healing abutment. I'm pushing the tissues more and more mesially and distally to get a better emergence profile. And this is what I can call a good emergence profile. You know, it's like a reverse hourglass. This is a good emergence profile. You see the tissues? All tissues are coming divergent. And now I have a thickness of soft tissues in the interproximal area. So this is called a reverse mid-crestal incision, and as you can see, it's really easy to do it. Number 2 is a pouch technique. Pouch technique is a technique used to increase the peri-implant soft tissue. Let me explain to you. If you have a thin gingival bitype and you can see you have a defect and you have a thin gingiva around your implant, how can you manage this? I published this in 2016 and I called it a minimal invasive pouch technique. What I'm doing in this minimal invasive pouch technique, let me also explain to you by this video animation. Minimal invasive pouch technique. All what I'm doing is that I'm doing a mesodistal incision, just one incision. You see, I'm looking for simplicity. So just one incision and pushing my periosteal elevator, pushing with my periosteal elevator, creating the pouch. It's a full thickness flap, very easy to do, creating the pouch and inserting inside the PRF or inserting the CGF inside. Taking suture. Okay, what will happen here? Now the PRF, in the beginning, PRF will act as a filler. Why? Because already you created the pouch, you push your tissues horizontally, buccally, you have a gap. You fill the gap with PRF or CGF. So in the beginning, PRF or CGF will act as a filler to prevent the soft tissue to collapse back palatally or lingually. So now I have a filler. What's next? Someone will tell me PRF will resorb, doctor, and the tissues will go back in its normal or the previous position. No, PRF will not resorb. PRF will be a matrix for the new tissues. PRF will accelerate your own connective tissue graft formation, and the fibrin network will become a niche or a matrix for the new connective tissue. So now you are creating a connective tissue for your patient. It's his own natural inside to connective tissue. So you see, it's very easy. Let me show you some cases. I placed in this patient an implant immediate after placement. I placed the implant palatal. Of course, as you all know, you have to fill the jumping gap with a bone graft here. But this didn't stop the horizontal bone resorption. And I have a horizontal resorption, but my implant in a good position, and I have a good bone around the dental implant. My patient, she was a female, she told me, doctor, I'm not happy. I don't like this depression. You have to do something. I told her, okay, I'll take a connective tissue graft. No, doctor, please don't take tissues from somewhere else. You are butcher. No, please don't do this. So she's not happy with this depression. You know what is this, by the way? Always you have this, or you have a depression, because here you have a cover screw. So always inside the cover screw, there is some bacteria inside that prevents the tissues that close properly in thin gingival vita. Anyway, the patient told me, doctor, please, you have to do something. I don't like this. I told her, okay, I will do it with a nice way, and I will do my pouch. This is a pouch. I created a pouch, and I put my CGF inside. You see here, more and more CGF inside. And you see at the end, I put a piece of CGF between the healing abutment and another part inside the pouch. And the next picture, I want to give it Oscar Best Picture in this lecture. Why? This is what I was telling you. PRF or CGF won't resorb. It will become a part of the new tissues. Look at the tissues here. Look at the color. This is the remaining of the fibrin, and this is the new tissues in between. Let me show it to you with a magnifying lens. I will show you now with a magnifying lens. You see here, the white color you are seeing here is the fibrin, and the red color is the new tissues in between the fibrin network. So now we see our PRF or CGF is becoming a part of the new tissues. I have a lot of cases for a reason or another. I couldn't put back my flap. I have eroded bone. Simply, I cover it with CGF or PRF, and a few weeks later, the patient comes back to you with a fantastic soft tissue over covering the bone. And here you can see up here, we have a very nice soft tissue contour, much more better than the previous one. Here is the previous one, and you can see in the previous one, soft tissue contour is not nice, but post-operative is much more better, fabricating the restoration for my patient. And then my patient came back to me 1 year later to clean, to check the restoration. I took out the crown to clean, and you see it still have a very good soft tissue contour 1 year later, and I have 5 years later follow-up for this case. She was just here from a couple of days ago. Everything was perfect. Stabilization of buccal soft tissue, no more depression. I have no more depression. The soft tissue or the buccal soft tissue is totally stable, and I have no problem at all. So you see, it's easy. I have a question here, but I will answer all questions after I finish, no problem. And let me show you another case. This is a video, you will like it. I still have the same problem, I still have the same defect, soft tissue defect, but this is before placing the implant, or after, maybe yes, it's after placing the implant. What I'm doing, because I'm always placing my implants flaplessly, so I place my implant flapless, and I started to create my pouch. Here I used a big periosteal elevator. Actually, I had to use a small one. So when you are creating your pouch, use a small periosteal elevator. But you see, I'm creating the pouch. I'm inserting now the CGF inside. It's a little bit difficult, not that difficult, but you can see it's not that easy to put the CGF. It needs patience from you. You have to be relaxed to do it slowly. You see, I'm pushing the tissues horizontally more and more. And putting healing abutment, and then you see here the results are much more better. I will show you pictures for this case. This is a pre-operative, and then putting the PRF inside or CGF inside. This is what I was telling you. I put the last layer is a piece of CGF between the healing abutment and other piece or other side inside my pouch. And now you see I have much more better soft tissue for this case. And 3 years later, look at the soft tissue, fantastic. Let me show you before the 3 years, 1 year later, or sorry, six months later, it was like this. And actually I wasn't happy. I wasn't happy because it's like rich lab. The crown is covering the mucosa. To have a good aesthetics, the crown has to come from inside your soft tissue. So you see here, you see after 3 years, what happened? I will tell you what happened. You are very gentle with your tissues. You are very gentle with your patient. You didn't do a traumatic procedure. So this is a good outcome when you are dealing with someone in a gentle way. You know, when you are going to a girl and you'd like to talk with her, you have to wait after or either telling her, come on girl, let's go to have a coffee together. Or maybe you can go with some flowers, telling her, hello, how are you? You are very pretty today. Would you like to go to drink some coffee? This is what I'm doing with my tissues. I'm dealing with the tissues with a minimal invasive way. I don't open a big flaps. I don't take tissues from here to put it from here. No, when you deal with it in a nice way, you will have a very good end result. So keep it simple and silly. Keep it simple and silly. As much as you will go in a simple way, as much as you will have a fantastic results at the end. I'm showing you another technique, which is a Vista technique. It's a modification from the pouch technique for different cases. When you have a defect, and also when you need to pull your tissues or to push your tissues apically more or crustally more, you do this. You have a defect, but you do this tunneling or vista. So you make an incision like this, and again you're creating your pouch. It's the same with different approach. So you are pushing the tissues, and it's the same. Here you have a benefit of what? Of pushing the tissues towards the crown. For example, if you don't like your margins because you need to push the tissues more coronally, so do this and wait for a few months, you'll find that your tissues are going more and more coronally. You see, I have here a defect. Patient doesn't like the defect, so just a minimal exposure, one incision, only one incision, and putting your periosteal elevator, creating your pouch, inserting the CGF inside. You see here, there is no more defect. It's much more better. Here is a pre-operative, the patient didn't like this, and here is a final, much more soft tissue contour. And when you wait more and more, you will get much more better soft tissues around your dental implant. And 1 year follow-up, it's much more better than the previous for my patient. Another case, the patient came to me, she placed implant with another surgeon, and she told me, doctor, I don't like this. You see here, I don't like this depression. I told her, okay, I will manage this. So again, the same approach from here. Incision, creating my pouch, pushing the tissues. You see already, while creating the pouch, already the tissue started to go coronally. This is what I want. So when you put your CGF, the tissues will go coronally more and more and more. Putting my CGF, taking suture with a minimal, it's a minimal trauma for your patient, and it's much more better. It looks natural now. You see the pre-operative, she didn't like this, but post-operative, the tissues, the periapical tissues is much more natural. And I know I've done this case from 4 years ago. If the patient comes to me later, it will be much more better. But the patient, I don't know, it's in India it's the same or not, but in Egypt, the patient, if he's not suffering from something, he will never come back to you. He only come back when he has a problem. And our last technique for soft tissue management in static zone, which is a custom made healing abutment. Actually, I told you we are using a healing abutment. What is the role of healing abutment? The role of healing abutment is to reshape your soft tissue. In any implant company, you have different shapes of healing abutment. You have, for example, divergent healing abutment, 6, 7, 10, 15 shape of healing abutment, which we can call a standard healing abutment. And what is the role of healing abutment? Is to reshape your soft tissue. But let me tell you something. My soft tissue is not like his soft tissue. It's not like his soft tissue. It's not like his soft tissue. So I can't use 1 or 2 or 10 healing abutments for manipulating soft tissues of all my patients. I need a custom-made healing abutment for my patient. Here I'm not using anymore a normal healing abutment. I'm using a temporary crown instead of using healing abutment. Why I'm using a temporary crown? Because the harmonious emergence, it creates a harmonious emergence profile. And the harmonious emergence profile is really essential for aesthetic results that equal natural teeth. You need to manipulate your soft tissue. Standard healing abutment doesn't allow for a natural contouring of soft tissue, but temporary crown can do it. Temporary crown, and I believe this is the answer of the question. temporary crown, maintaining the aesthetics during the healing period, and formation of the emergence profile, which is really very important. And it allows aesthetic evaluation and phonetics for future restoration. So we are using a temporary crown instead of using a normal healing abutment. And let me explain to you what we are doing. Oh, again, it's a buccopalatal incision to create the papilla, then a narrow healing abutment. Then after 1 week, when taking out the narrow healing abutment, I put instead of putting wider healing abutment, I use a temporary abutment to create a temporary crown. Even I use a ready-made crown, but ready-made crown won't give you the emergence profile that you are looking for. So you need to reshape the cervical area. Reshaping the cervical area with flowable composite. So I put flowable composite according to what? What is the guideline for putting flowable composite? Nothing. I put flowable composite according to what I see, but this is not scientific. There is nothing in the science called according to what I see. So, but let me show you how can we solve this problem. So now I have a temporary crown with a very nice contour in the cervical area. I put my temporary crown and look at the soft tissue healing later on, start to become very nice soft tissue, and later on much more better. But I told you, to put a flowable composite, you need the guidelines. You need a guide how to put your flowable composite. A brilliant surgeon in the States called Dr. Baron Grutter, he invented something. He created software or a plug-in on software called Blender. On this software, all you have to do is to enter number of your teeth, shape of your teeth, size, small, medium, large, and you will have this 3D printed, 3D block. Then you can print it on a 3D printer. You can enter, you see the emergence profile, deep bowel, hourglass, or whatever, and you print this on 3D printer. I would like to show you one printed. You see, I print this on 3D printer, and then what I'm doing after, I put my healing abutment, a plastic abutment, which is a temporary abutment or a final abutment, whatever, and I put my flowable composite inside. What you can see here, you can see the right emergence profile for the molar, for the premolar, for the anterior. This is the right emergence profile. So when you add the flowable composite, you are adding it with the right way. Let me show you how to do it in this video. First of all, you put your, I don't know what is happening with the video, it will start now. Yes, it's working now. I'm creating a custom-made healing abutment for my patient. So you see, first of all, I put separating medium in the model, and I put acid etch and bond on my temporary abutment. Then fill the gap with a custom-made healing abutment. You can add even more composite to fabricate your crown, your temporary crown over it. Curing, and now what you have? Now you have your custom-made healing abutment. This is very good. Let me show you. You see, I have a custom-made healing abutment here. Here I have a custom-made healing abutment with composite, so I can use it for my patient. You have one healing abutment for each patient. So for each patient, you have his own custom-made healing abutment, which is very good for your patient, of course. And let me show you a case. I will show now a very nice case using this custom-made healing abutment. Of course, now you can combine both. You can combine the custom-made healing abutment with any different technique. For example, you can combine it with the buccopalatal incision. You can combine it with a pouch. You can combine it with any kind of techniques you are using. I don't know what is happening to the presentation. Excuse me, I don't know. Freeze. Okay, it will work now. Let me show you this picture. This patient came to me with a trauma. He had an accident and totally extracted upper central. And for the other central, you see it's broken. And as you can see, the buccal plate of bone is very thin or completely absent in one of them, and in the other, it's very thin. The ideal treatment plan for a case like this one is socket preservation, grafting, then placing the implant later on. But as you can see, you have a treasure of palatal bone here. So you can place your implant palatal, and normally we place our implant palatal. So you can place your implant palatal. Here is the preoperative. I opened my flap. It's a big mess. He has a big problem, a lot of bone resorption. And as I told you, the best thing to do is to just simply do a socket preservation. But I created a new sockets in the palatal aspect, because everyone placing implants, he knows well that you can, in upper anterior, you have to place your implant palatal as you can. So you see parallel pins, and now I have two new extraction sockets, or two new sockets or osteotomy sites for my implant. I place my implants, one implant, second implant. Of course, I have exposed threads over my implants, but it's okay. I can fill all the gap with bone graft because I have 5 walls defect. It's perfect. So I'm using sticky bone, allograft with sticky bone. So I'm covering the whole implant with sticky bone, taking sutures, and then later on, now I need to create papilla. What I'm going to do is simply one buccopalatal incision, narrow healing abutment, and look at the picture. You see the mesial and distal blanching. Why? Because the tissues, the healing abutment is pushing the tissues mesially and distally. Then I take out the narrow healing abutment. I put my custom-made healing abutment, and over it I created the 2 temporary crowns. Now I have a good emergence profile for my patient, taking an impression. And first of all, look at the preoperative X-ray. Look at here, no buccal plate of bone. I place my implant here. Yes, I placed my implant here. Look at the bone, look at the pre, and final. I have a very good end result for my patient, and final restoration was good. The patient was so happy. I was so happy. His mother was so happy. Everything was okay. Another patient, this patient came to my practice. One of my colleagues treated this patient. He didn't like his appearance, so we had to take out the bridge, and he was asking for 2 implants here and there. My colleague placed the implant and sent the patient to me to make the soft tissue management. Again, a buccopalatal incision. My custom-made healing abutment. Look at the soft tissue. The issue is the tissue, as they always say. The issue is the tissue. Look at the healthy soft tissue. Look at the soft tissue after custom-made healing abutment. I have a much more better soft tissue contour. Look at the papilla here. We created a papilla with a soft tissue contour, and then the final restoration was satisfactory for my patient. He was happy with the soft tissue. I was happy also with the soft tissue for the patient. Patient was totally happy with the soft tissue contour. And of course, he needs veneer in the neighboring teeth because of the hypercalcification. But at the end, she was happy. She was happy with her smile. We sent her to a colleague of mine, and he fabricated the veneers for her. Another patient, again, we are doing the buccopalatal incision. One of my colleagues, well, my teamwork, placed the implant. We created the buccopalatal incision, and then what's next? A narrow healing abutment. We put a narrow healing abutment for the patient. As you can see, this is a thin gingival bite type patient. It's obvious. It's the same gingival biotite patient. We placed a narrow healing abutment. Then 1 week later, we took out the narrow healing abutment. We put the wide healing abutment. Not wide healing abutment, we put the custom-made healing abutment for the patient, and then we fabricated the final restoration for the patient. Here is a custom-made healing abutment. You see here, I have a much more better emergence profile for the patient. And then we fabricated the final restoration. Here is a day of cementation. It's not that perfect, but look at here, I have papilla. Because I made my buccopalatal incision, narrow healing abutment, wide healing abutment. Now I have the papilla. So what's next? Let's take a look. Couple of months later, wow, soft tissue is much more better here. Soft tissue is the issue. Again, I'm telling you, if you are dealing with your soft tissue with a less traumatic way, you will get a fantastic outcome from your soft tissue. And jumping finally to the conclusion, implant therapy in the static zone requires careful planning and sequencing of treatment. Hard and soft tissue deficiency may require multiple procedures and have varying degrees of predictability depending on the size and nature of the defect. Preservation of the natural soft tissue architecture may optimize results and decrease surgery-related morbidity. The use of growth factors concentrates in the form of PRF, CGF led to better aesthetic results on soft tissue level with the advantage of less invasive technique and better wound healing, which enhance the clinical end results and increase patient satisfaction. And at the end, I'm asking you, do you know who is this girl? Cinderella. Of course, all of you know Cinderella. What is the moral of the story of Cinderella? Cinderella never asked for a prince. She was looking only for a night off and a dress only. She didn't ask for a prince. Just she wanted to attend a nice party. But she has done everything with a perfect way. So the prize was a prince. So what I'm trying to tell you here is that you have to be less traumatic for your patient. You have to be nice for your patient, not only for your patient, for your patient's tissues. Because if you do it with a simple way, with a less traumatic way, you will be surprised from the outcome. Don't tell your patient, I will take tissues from here to put it here. Look at this picture. Your patient see you like this. You are very scary for your patient, by the way. Every one of you knows that the first thing the patient is telling you, doctor, I hate dentists. I know that they hate me. So, because look at this picture, you are very scary for your patient. So please don't be scary for your patient. Don't tell him, I'll take tissues from here, put it here. I'll put bone from here, put it here. No, please try to do it in a simple way. And I already explained to you how to do it in a simple way. Thank you very much for attending the lecture. If you'd like to contact me, this is my email down here. And this is my Facebook page. I really feel so happy to be here with you this evening. And I really appreciate the invitation for this lecture. I hope it was beneficial for you and I hope you like it. And I'm here for your question if you need to ask any question. So is there any question? I have a question. What is the name of the customized abutment template? Let me just a minute. Okay, I can see the questions. What is the name of the customized healing abutment template? Look, it's not available anymore for sale, this software. But anyway, it's called Blender. Software is Blender, and the same, and the whole procedure called anatomic profile generator. It creates this, and the one who invented this, he invented something called anatomical profile generator 2, which you can use it. You will find it for free. Just search over the internet for anatomic profile generator. Another question. Let me check, because there was a question in the beginning. Another question. It was good to take so many points from you. I want to ask if we can customize abutment in our clinic. Yes, you can do it in your clinic. If you don't have this block and you don't have the software, you can simply, as you have seen in the pictures, just add some flowable composite around your temporary crown. It will be much more better than using a normal healing abutment. Okay, any other questions? Another question, sir, is it okay to give immediate temporary after implant exposure for soft tissue contouring? Yes, this is what I answered you. We are using a temporary. Temporary is giving you a much more better emergence profile than using a normal healing abutment. Okay, any other questions? No other questions? So again, I would like to thank the World Dental Association page and Dr. Anand Muhtada for inviting me for this lecture. And I hope you like it. I hope you enjoyed being with me today. I enjoyed being with you today. And please stay safe in Corona time, because we're in the lockdown. I don't know if you have a lockdown in India or wherever in the world you are. We are in lockdown. We are not working a lot. And I want to tell you something. The world after Corona will be totally different than the world before Corona. And you have to use your time. Use your time during the lockdown to increase your knowledge, to increase your skills. You have thousands of free online lectures. Now I've seen lectures for speakers. I used to pay thousands of dollars to attend the lectures. I've seen it for free. So please make use of this time. Make use of your time to increase your skills, because after Corona, everything will be totally different. After Corona, people who stayed in the lockdown doing nothing, they will stay nothing. But people who use the lockdown time to increase their knowledge, to increase their skills, they will be much more better. Thank you very much, and hope to be with you in another session. And I already answered the question, can we customize abutment in our clinic? I already answered it. Thank you very much, and I hope you like the lecture, and see you in another lecture. Thank you, and have a nice day. Have a